Very good morning. I bring greetings from the Indian Society of Gastroenterology. A warm welcome to another session of ISG Masterclass. This is Series 4. I am Matthew Philip, the Secretary General of Indian Society of Gastroenterology. The theme of this series is Challenges in Day-to-Day Practice in Gastroenterology. We have eminent speakers and very experienced moderators for this session. I acknowledge the efforts taken by the past President Mahesh Goenka, the President-elect Dr. Govind Makharia, and all the governing council members, especially Sudipta Dar Chowdhury and Bhaskar Nandi, who took special interest in charting out this schedule of topics. The previous sessions were well attended with very meaningful interactions with the faculty. I would like to inform some housekeeping announcement also for the participants. Please post your questions and we will try to address each and every questions or issues raised. Now, may I request the ISG President, Dr. Sandeep Nijavan, to take over the proceeding and introduce the moderators. Thank you.
Yeah, good morning, everyone. Greetings from the Governing Council of Indian Society of Gastroenterology. We are into the fourth series of master classes, and second of this one in this series. And this time, as we are actually into the other side of the coin of gastroenterologists, similarly, we have to see the other side of a therapeutic endoscopist. And we have a galaxy of speaker and moderators with us who have the greatest experience in India about therapeutic endoscopy. We have Dr. Rakesh Kochar. He is teacher of teachers. He has served for 4 decades at PGI Chandigarh, and now he has a very strong second innings at Fortis Mohali and Paras Hospital, Panchkula. We have Randhir Sood with us. He is another great teacher of the teachers. He is teaching all of us for last 4 decades about therapeutic endoscopy. He is the chairman of Institute of Gastroenterology and Hepatobiliary Sciences at Medanta. These two moderators have the greatest experience about the therapeutic endoscopy. They will also tell us about the other side of the coin of a therapeutic endoscopy. I'll ask the moderators to carry over the program forward and introduce the speaker.
Next slides, please.
Yeah, thank you, Dr. Sandeep and Dr. Matthews. See, it's my privilege to introduce Dr. D. Nageshwar Reddy. If any one of you do not know him, then I don't think you need to be in this field, because he is the face of GI endoscopy of India. And he's an inspiration not only for you guys, he's an inspiration to people like me too, because he's the achiever who not only achieved excellence in endoscopy, but also excellence in creating institutions as well as creating standards which are raising the bar of GI endoscopy in India to a level that everybody tries to achieve that. So he is in recognition of his contributions, he's awarded the 3rd highest civilian award by the President of India, Padma Bhushan, and he's the chairman and founder of Asian Institute of Gastroenterology, Hyderabad, one of the biggest GI institutes in the world. And I'll invite him for his talk, and I'll hand it over to Dr. Rakesh Kochar to introduce the subject.
Thank you, Randhir, Sandeep, and Matthew. This second talk of this series on master classes is by Dr. Nageshwar Reddy, and the topic, which concerns all of us, which every endoscopist faces and deals with, is complications of endoscopy, something which we dread, and we are very wary of that. And at times we find ourselves in a dilemma what to do it ourselves, to refer to a surgeon, or ask a colleague. So the fact lies that we should not sit on ceremonies or ego, and do the best which can be, which should be the best for the patient. So to discuss all about it, I invite Dr. Nageshwar Reddy, whom Dr. Randhir has already introduced. Nagi, please, all yours.
Thank you, Rakesh. Thank you, Randeep, for the kind introduction. And thanks to ISG for giving me this opportunity to give this very prestigious talk. Now, can we share the slides? I think you can share the slides from there. Enable us to share the slides. You have to enable us, yeah. So when Sandeep, I think Matthew by introducing, they said, we have been selected, both the speaker and the moderator, because they are the most experienced. I hope it's not the most experienced in complications. We, of course, probably have the most experience in complications also, because as the number of endoscopy increases, we are bound to catch up with the statistics. There can't be any interventional endoscopy without complications. So this, of course, probably is true in a way. Now, the first thing I'd like to state, friend, is that endoscopy, when it started as a diagnostic procedure, was not very invasive. But as we grew, as it became more interventional, it became more and more invasive and therefore potentially hazardous. There's been a difference, however, between surgery and endoscopy. When patients go to surgery, they go to an operating theater on a stretcher. They've been talked about potential complications. And if the patient comes out alive from the operation theater, the relatives are very happy. In the endoscopy unit, unfortunately, most of the time the patient is walking in, sitting up, and then if some complication occurs, even if it comes out on a stretcher, the relatives are very unhappy. So there's a slight difference between what happens in endoscopy and operation theater in terms of complications. That's why in our new unit, we changed the whole philosophy that every patient has to come to the endoscopy room on a stretcher and go out on a stretcher, of course. Then the patients are not very worried. Now, let me start first with this definition of complications given 30 years ago by Peter Cotton. He said complication in endoscopy is an unplanned event related to procedure that requires the patient to be admitted or to stay in the hospital longer than required or undergo an unplanned intervention. Now, this definition became not only complicated, but also created a lot of problems among endoscopists and, of course, patients and relatives. So later on, you can see in 2020, Peter Cotton was asked to see whether he can review this, and he, along with a group of top endoscopists, reviewed the definition. Endoscopic complication was changed now to one adverse event, which means that if the procedure, during the procedure we abort, we are trying to do, say, a third space endoscopy, patient becomes very sick, you stop doing it, it's called an adverse event. But if the patient, if you complete the procedure, still some problem occurs, it's called unplanned event. So most of the things that we're going to talk about today are unplanned events. For example, bleeding, you didn't plan for a bleeding, but it occurred, but your still procedure is completed. So it's not complications. So I think, at least for our younger colleagues, it's very important to start thinking differently and start not reporting as complications, but as unplanned event or adverse event. Most of them, it's unplanned events because most of them were able to correct endoscopically and complete the procedure. So this is a very important definition that I'd like you to understand. Because look at this, we actually had this paper in GI Endoscopy sometime back where we talked about adverse events in endoscopy, and editors printed this as one of the adverse events. These are actually unplanned events. In patients, when they're doing POEM, you find air in the retroperitoneal space, you find air in the pericardial, peripericardial area, and so on. These actually were unplanned events which cannot be called complications. So we have to change our definition of complication to this now. So what are the adverse events that can occur? That is where you can't complete or something has happened afterwards. So these so-called adverse events can occur before the actual procedure. For example, when you're preparing colonoscopy, you give large amount of fluid, the patient develops a perforation or obstruction, or during, which can be perforation, bleeding, and so on, or even after the event. For example, post-ERCP pancreatitis typically occurs afterwards. In fact, this is subdivided as will come later. So you can have an adverse event occurring before, during, or after the procedure. So what are the endoscopic complications or adverse events? It's very easy to remember. There are only very few, direct or indirect. The direct ones are bleeding, perforation, infection. There are others which I don't want to go into in detail, like stricture formation and so on, which are very small. but basically only three: bleeding, perforation, infections. The indirect ones are cardiopulmonary sedation related, usually aspirin. And what is very surprising is there is now a large amount of data available from good endoscopy units which have reported their complications in audit form, that 46 to 60% of endoscopic adverse events are because of anesthesia or cardiopulmonary related. They're not because of endoscopy itself. Endoscopy itself constitutes a smaller fraction. So it's very important to remember that adverse events are because of these cardiopulmonary events, because of sedation related to patients. And therefore, in an endoscopy unit, it's become very important, mandated to have good monitoring equipment. And my own suggestion to endoscopists that are growing is that kindly don't try and do your own sedations. Try and develop this habit of having somebody else to give sedation, especially propofol. Monitor these patients well, because this ultimately is going to be the major cause of adverse events in an endoscopy room. So let's come to actually the procedure related. The first, as I said, is bleed. Next is perforation. Third is infection. I shall go through one of them one by one. So bleeds can occur actually during the procedure or after a procedure, especially, for example, a polypectomy you do. It can be early before 48 hours or delayed after 48 hours. This is the ISG definition of procedure-related bleeds. So whenever you're reporting this, you have to report as a bleed occurring as delayed if it's after 48 hours after the procedure. So what are the risk factors for endoscopic bleeding or intra-procedural bleeding? Of course, coagulopathy, and nowadays a lot of patients are on anticoagulants or aspirin and clopidogrel. These are very important. But unfortunately, in endoscopy literature, there is not much emphasis or there are not many studies which actually looked at the need for doing coagulation parameters before a procedure. For example, we are told before doing an endoscopic sphincterotomy, there is no need to do INR. There are no guidelines available to suggest whether you should do INR or not. So again, it depends upon the sickness of the patient, how careful you are, whether the patient has an associated liver disease, you want to do an INR before doing a sphincterotomy or not, but guidelines do not suggest this. The other important thing about bleeding is delayed bleeding is very important, and recognition of this delayed bleeding. Very often you do a procedure, patient goes home. After 48 hours, you find that these patients come back in a state of shock. So if there's any suggestion that, for example, I'll show you some examples also, a large polyp more than 2 centimeters, just observe for the first 24 hours. Most of the bleeds can be managed endoscopically. Very rarely you require surgery. Again, I'll show you examples. So let's come to specific areas. First, variceal bleed. So when you do variceal banding, you'll find that sometimes even after the band is over, patients come back with a large bleed like this. Very difficult to control. This post-variceal ulcer bleeds especially. Of course, we now have the new Danish stent. And in majority of the cases, we have found that although in the Western literature, they suggest tips and so on, in our patients, the Danish stent is sufficient. And this is an example of a patient who had banding done, came with a massive bleed after banding. 24 hours later, because the band slipped off, we are putting in the Danish stent, which is a fairly easy procedure to do. We don't require fluoroscopy, in fact, but we did it here under fluoroscopy. And this will almost always control the bleed. So if you have post-variceal EVL banding, the thing to do would be this stent to stop the bleed. Now, look at another thing. Third stage, you're doing myotomy and you start getting a spurter like that. Very easy to control. This, in fact, we don't even call it an adverse event. It's an unplanned event. So we use the cap, press the bleeding area, accurately assess using a water jet, and then do this co-op gas coagulation using soft coagulation. Very, very important for the young endoscopists. Always have a endoscope which has got a water jet. You should not do therapeutic endoscopic procedures like third space without a water jet endoscope. Now, again, they're doing a stir here, and you can see in stir, you can get really massive bleed because large vessels are there. Very easy. You can just localize these vessels and very easily control these vessels now. There's no difficulty involved at all. And I think this is important to realize that many of these bleeds can now be controlled. Now, what I would normally do is keep certain things ready when I'm doing these procedures and have a diluted epinephrine spray in a bottle there, submucosal injection devices like, for example, Carlock's needle, thermal coagulation devices, a hemostatic forceps, and a triangular knife. If I want to do a spray coagulation to stop the bleed, I use a triangular knife. If I want to use the hemostatic forceps, I use a coab grasper, which for me is the best one. There are many hemostatic clips available. Keep the ones which you have used before, and they're again a separate topic by itself to discuss. So if you have a bleed like this after an ESD, for example, we are doing a gastric ESD in this patient, and he starts bleeding. Again, it's a combination where you have to visualize the vessel very carefully. You can see a spurting vessel here. Because we have a cap, all these cases you have to do with a cap. You can very easily localize the area of bleed, and for any vessel more than 2 millimeters, it's better to use a co-op grasper, although some people tend to use the same knife. So the general rule that I would suggest is the following, again for PGs. If you have a small vessel when you're doing ESD, bleed occurs less than 2 millimeters, the same ESD knife, the triangular knife or the dual knife, whatever you're using, you can use to stop the bleed. But it's a larger vessel, more than 2 millimeters, kindly use the coagulation forceps, because for these large vessels, coagulation forceps is the best. So have this always with you, and you can see the currents we use with soft coagulation with a coagulation forceps of 80 watts, whereas with when you're using these other knives, we use a SIFT coagulation with 50 watts. So just remember this blindly, put these settings, and then you can almost always stop these bleeds. Now, so what has happened in recent years is our ability to actually use certain new advances in endoscopy. And this is an example of the RDI, the red dichromatic index we're using. And in this case, you can see we changed to that and the bleed looks very soft. Let me show this example better to you. With red dichromatic imaging, we can now actually look at the deep blood vessels. So even before starting the cut, you can prevent bleed from occurring. And even when you do the cut, if a bleed occurs in these cases, we can switch to RDI. And what happens, two things happen. The bleed itself becomes less red, so it calms our mind, and you can really easily control the spurting point. Now, if we have an active arterial bleed during the resection, always use a co-op forceps. Only after you finish the resection can we use a clip, because if you use a clip during the resection, unfortunately, you can't complete the resection. Now, let's come to polypectomy, because this is the commonest type of situation you have in practice, colonoscopic polypectomies. In general, again, this is a very good studies to show that polypectomy bleed incidence increases if the polyp is more than 10 millimeters, if it's a villous architecture, if it's high-grade dysplasia, right colonic location, if the patient is on antiplatelet drugs or anticoagulation. So these are the situations. So what we now have is, again, to keep certain devices ready when you're doing polypectomy, just keep it aside, especially these clips, through the scope clips which are there. So if you have a high-risk patient, can we do, especially the pedunculated polyp, can we do a prophylactic bleed prevention? So again, epinephrine injection is to be used a lot. When we were training, that was the main method. But we now switched to prophylactic clips or detachable snares for pedunculated polyps or more than 2 centimeters in size. And this is a classic example. A pedunculated polyp, large in size, we put 2 clips on either side. Larger clips are also available, 16 mm opening now. And then we cut very safely without any problem. Similarly, and this has been, I think, shown in several studies. This was a very important study in GI endoscopy, which actually did a randomized trial comparing, showing that prophylactic clips are useful. Large polyps, more than 2 centimeters in size, kindly use prophylactic clips. Similarly, if you have the other alternative you can do in this patient, to use a detachable snare. And this is an example of a patient we saw, very large. It was about 4 centimeters in the head. We use a detachable snare. This is available now from many companies. So then we use a snare to cut it out. So again, this is a standard principle. So very large, use snares. If it's not very large, you can put 2 clips to cover the base. So this is how we can prevent. But during the procedure, if you have a bleed and you finish the procedure, then putting clips is often enough in most cases. The other very important emphasis is on colonic mucosal defects after EMR. It has been shown that if you do a large resection, especially more than 2 centimeters in the right colon, delayed bleeding after 48 hours increases significantly, especially if the patient is on antiplatelet drugs. So in all these patients now in the right colon, to avoid this delayed bleeding, we use prophylactic clips. So this is again showing you that after the procedure, you can use clips to stop and then clips to completely close the bleeding. And clips, I think, are something that you must be very familiar how to use this with us. Okay, so this is rarely you can use a heater probe, especially if the clip is in a different location. We are used actually the probe that's now available from Boston, the gold probe, which is they're now available. Now coming to ERCP related bleeds, again, this is not a major problem now. As soon as we see a bleed like this, we inject epinephrine. Then, of course, the choice is between clips versus thermal hemostasis. I prefer to use a thermal hemostasis with co-op grasper. The only thing to remember is co-op graspers are difficult to get up the elevator. There's a new one which is now going to come into the market, which can be very easily manipulated with the elevator that can be used. And still, if it is not useful, completely covered SEMS. And of course, we always have our radiologists coming in if you still can't. Very, very rarely, and something that I'd like to discourage here is the use of a surgical help in these cases. Post ERCP bleed, surgery is extremely difficult even for the surgeons. You should stop at the angio level. And these are examples of bleed at the side where you put a clip to stop the bleed, but very often we use the... Now look at this patient who had portal biliopathy, stones were there, and we started removing the stones, and when the last stone was being extracted, you can see that we ruptured one of the varix inside, and you can see the type of bleed that's occurring. In these bleeds, the only way you can control this bleed is to immediately put a completely covered stent. And once you do that, the bleed very dramatically stops, and then you can see this situation here. So I think this is very important to realize that this. The other thing, I show this video very often. I think Randhir and Rakesh must have seen this also, that this is how is very important. This is a polypectomy, ampulectomy being done by Michael Buck in one of our workshops. So bleed occurs after the ampulectomy from the two large vessels at below the papilla. And the most important thing here is to realize that not to get tense, to be very calm, to discuss with the assistant what type of accessories you require. And in this case, you can see what Michael is doing is that he's using a co-op grasper to burn on the bile duct side, but near the pancreatic side, he's using a clip because he doesn't want to have any heat damage to the vessel. Towards the bile duct, he's using a co-op grasper, and the bleed is controlled. So plan what you're going to use before itself, be very calm, tell your assistants, and this is again very, very important. Fairly massive bleeds can occur during endoscopy, and how we control the bleed depends on the main endoscopy, the main actor, because others are following him and they start getting worried if these bleeds are very high. So this is very important to realize. Now the new technology is coming in, but before that, during endoscopic ultrasound also we get bleed. And this is, look at this, we're puncturing a wound and you find there's like a jet coming in. And this is called the fire-breathing appearance, which we see in a patient in whom we hit a vessel. Again, don't bother, be very calm. Just put a completely covered stent and the bleed immediately stops. So bleeds during this type of situation, again, are controlled by stents. And you can see that the bleed has stopped immediately. When you're doing a necrosectomy in the wound, you can get a bleed. And this type of situation, you can see this area, you can go in and clip it, but not so easy always. Here we could actually see the vessel which was bleeding, and so that we can put multiple clips. But this is a rare situation where sometimes the patient may have to go for surgery when the bleed is very massive. And of course, it's almost always controlled easily at that point of time. So this is another very unusual situation. Sometimes, again, this is where we took a surgical. This was a patient, so-called visible vessel. When we put in a clip on this visible vessel, you can see what happens. As soon as the clip is put in, there's a massive bleed because there's a pseudo-aneurysm below. And you can see when he went for surgery, the aneurysm was actually seen very clearly, and the surgeon could control it. These are rare situations where they go in, and usually in this type of situations, you must have your surgical colleague around or inform him that this is being done so you can take up. But again, in general, what I like to tell you is that surgical intervention is not very useful for many third space bleeds, for ERCP bleeds. They are more useful for luminal bleeds, especially ulcer-related bleeds. And even there now, angio has been shown to be superior, or sometimes in wound-related bleeds. Now, the new technologies that are coming in are, for example, there's some very new gel. This is a Purastat, which is a self-assembling peptide. When you do a ESD, there's some ooze there, and instead of completely controlling it and having a delayed bleed, you can actually spray the self-assembling peptide, Purastat, and this is shown to reduce or in fact make it zero, the delayed bleeds. Two other are available now. A Korean company has come up with a very nice gel which is marketed by Olympus. Similarly, next generation next spray is available from Medtronics, which are all having the same efficiency. So you have to keep some of these in your departments, and if you're doing a large ESD, I would suggest use this sprays so that it actually forms a coat on the surface, and delayed bleeds after 48 hours are decreased. So this is regarding the bleed. The next complication that we come across is perforations. And this is, should we stop here, Matthew, before we go?
Yes, I think we can stop here and we can have the poll question. Dr. ND and Rakesh Kochar?
Yeah. I think we should have the poll questions now as we had planned, and then we can proceed with the rest of the talk so that we can see.
So we can have the first poll question here, I think.
Yeah.
Let's see what happens. The first one, PPT.
And we'll also request the audience to keep posting their questions in the chat box so that we can take them up and have the opportunity to answer all the questions.
The PPT is not coming up. Maybe some problem.
Yeah.
So there is one question that's coming up in the chat box. How to manage post-ESD bleed, that is endoscopic sphincterotomy bleed, and what should be the threshold for embolization? 99% of post-ESD bleeds, sphincterotomy bleeds, can be controlled endoscopically. There's the only threshold for embolization I found is in those who had an ampulectomy done, when the bleed is massive or delayed after 48 hours, you go in endoscopically is very difficult. So in these cases, I would recommend an angio, but even angio is very easy in these cases because you put clips. So our angiographists can go super selective and completely do an embolization of this area. So it's very easy. I would not recommend surgery at all. So threshold for embolization would be inability to control the bleed endoscopically, dropping hemoglobin or hemodynamic instability. Again, I'd like to tell younger colleagues, don't panic here because very often it stops spontaneously. It looks big bleed, but stops spontaneously, and you can follow up these patients. And if there's a dropping HB or hemodynamic instability, then you can go ahead and ask your angiography colleague. Now, the second question is post-EBL bleed, if Danish stent is not available, can a completely covered stent put in? This is again a very good question. We have found this, that if you don't have a Danish stent available, you can put in a completely covered, fully covered stent. The only difference is fully covered stents don't have such a broad flange as Danish stent. Number two, they're not as soft. So I would recommend that even if you put a FAS, fully covered stent, take it out quickly, whereas Danish stent can be put for 2 weeks because it's very soft, and removal is by a special technique where you shrink the stent into a tube and take it out. This is not available with completely covered stent. So there's a little difference, but in emergency, you can use it. The third question is risk of delayed bleed. We are getting the questions. Okay, the questions, which one would you put first? No, yeah, this is the first question. I think we'll ask our participants. Oh, fantastic. Oh, 50-50, I thought.
It is just coming up.
It's still coming, huh? So it takes some time?
No. You can continue the discussions.
Yeah, they are polling.
So there, I think this is a bit like the TV, this thing, it keeps going up. But I'm surprised.
They are listening also.
I'm surprised that there's still 16%. That means some of them have joined late for the talk.
Maybe like that.
They missed the first point.
Now we can ask the question again at the end.
No, because when we
Majority
discuss,
are-
I think it's stabilized now or still moving.
Almost stabilized. Majority are with you.
Yeah, but I'm very disappointed that 15% of the audience still think that the commonest is bleeding. Because we told them that 56% of the complications or adverse reactions are cardiopulmonary. So they can change it now? No. Okay.
We'll put it across again because now they have
I
done.
think, okay, we take 90% are intelligent, 13% came late for the talk.
Yeah.
Okay, no, this we don't want the second one. We'll go later, second one. Shall we go to the chat box? There's some interesting questions, I think.
Now you
We
take
can go to the chat box. We can stop this questionnaire now.
Prashant, you can stop
We
sharing.
stop
I think the
yeah.
infection 2% are just having fun. They're not very serious. Yeah. So, next question was risk of delayed post-polypectomy bleed. Yeah, increased by hot biopsy forceps. Yes, I think that's the reason why there's a tendency towards going for cold snaring, especially for those polyps, sessile polyps less than 2 centimeters. Even more than that, people are now doing cold snaring because the incidence of delayed bleed is less. Can antiplatelet be started? Yeah. So this is a very important question. When should we start antiplatelets after the therapeutic procedure to avoid cardiac problems? Now, thrombotic problems. This has not been answered very, very well, but the best study we have is a study which came from Hong Kong, which suggested that after you stop the bleed, after 5 days, you can start using antithrombotic antiplatelets. But if the patient is sick in sense that he has a very major high risk for a thrombotic phenomena, then we would suggest that within 24 hours, you can use injectable form of heparin and then convert to an antiplatelet agent after 5 days. But 5 days is the usual threshold. Again, we don't have good RCTs or literature to support it, but this is a practical thing. What is the medico-legal status of endoscopist delivered sedation, especially propofol? Are non-anesthetist doctors eligible to administer propofol? No, anyway, I think this is a question that panel also can take up. In my view, we don't have any legal status in India. In Germany, for example, the endoscopists have a legal status to give propofol. In United States, the endoscopists cannot give propofol. If they give propofol, they can be sued. In India, we haven't discussed this question legally, but maybe the panelists would like to add Rakesh, Randhir, or
Randhir and Rakesh, please. Randhir, you have to unmute.
We have discussed this in our institution many times. The problem is with the Anesthetic Association guidelines, which have clearly stated that non-anesthetists cannot give propofol. But now they have the way out is that we are training our nurses to give propofol sedation under the anesthetist, and they are certified as anesthesia nurses, and they can give propofol under supervision of a trained endoscopist or a person who is trained in basic cardiopulmonary resuscitation, and intubation.
Professor Rakesh Kocha, your opinion?
Yeah, I think it is a problem in most places because anesthetists are not that readily available, and their time, they cannot spare so much of time. So at PGI, only the third space procedures are done under anesthesia cover. All other procedures are done with sedation given by the gastroenterologist only. The nurses are trained, of course, but not certified as Randhir suggested. In the private sector in Chandigarh, it is the nurses who give propofol, but again, they are not certified. So we need to have this consensus within our community in the gastroenterology that we need the nurses to be trained and certified, that because anesthetists will not come that readily as much as we want.
Yeah.
Sir, I think,
that's a question.
ISC should take it up
Yes.
as an issue. Professor Sandeep Nijavan, I think, this is an issue to be taken up. What do you think?
Yeah,
Now,
I think a supervision under the anesthetist is really required, because as a therapeutic endoscopy, you are actually concentrating on your patient, and you are little actually, you cannot concentrate on the general condition of the patient. So a supervision of anesthetist is really required, and I think the trained nursing staff can actually work under the supervision.
but
No,
in
I
my
think I think there's a big disparity between private sector in our country and government
Yes.
sector. Ideally, and like what we have done is we have almost 20 anesthetists working in our endoscopy unit. So if you have endoscopists covering at least covering 2 rooms, then that's good enough. But like Rakesh said, maybe for me and Randhir it's easy, but for, like Rakesh said, for a government setup, it is not so easy. And therefore, we'll have to think of an alternative in our country. And one of the alternative could be like trained anesthetic assistants. Either could be nurse, or even there's an anesthetic assistant course available now in most of the universities. It's a 2-year course where they're given training. I think we should now legalize it from the ISG side or SGS side, saying, okay, it's because sooner or later this problem is going to come into consumer court and we'll get into a problem. So it's better they take it up very quickly and legalize and say, you can have up to anesthetic assistant, there's no problem.
And I think the most important thing is that the one person in the anesthetist, in the endoscopy suite who can intubate the patient in case of an emergency has to be there. Unfortunate part is that most of the endoscopists are not getting trained to do that. They can intubate everything, but they have not learned to intubate trachea.
Sir, in our institution, it is fully under the control of anesthesia team.
Yeah.
They will do it. It's not, we have no right to do any of these things.
Yeah, I think this is a very important discussion. I'm glad it came up, and I think Sandeep and Matthew should take it up very seriously.
I'm happy to inform you. Yeah, I'm happy to inform you that from tomorrow onwards in our unit, we have a resident posted from anesthesia under the cover of a anesthetist consultant who is working in an OT above the floor.
That's very nice. Only problem, Sandeep, is that OT anesthetists think it's infrequent to come to endoscopy room. They don't like to come. Even the residents, the casual posting. That's the problem.
Okay, I think we'll move to
the questions quickly. We have some more questions. Amit is saying when the hemostatic powder comes, we have some local hemostatic powders available also in India. What about emergency management of post-glue bleed after gastric varices? I think this is again something we see often. I would suggest that if you have facility for US guided injection for both coils and glue, that would be best because we can actually go to the perforator vein and inject there. If you don't have the facility, again, re-gluing that area is very effective. And even if that, of course, you have interventional radiologists and emergency tips is very useful. Any specific management for bleed during ERCP or portal hypertensive cavernoma? Yeah, so if you have a portal hypertensive biliopathy or cholangiopathy, in these cases, of course, what we do practically is to give terlipressin IV just before the pulling the stone out and so on. In case bleed occurs, and sometimes it can, then of course a completely covered stent is very, very effective in stopping the bleed. For post-EVL ulcers, sclerotherapy is suggested, but I don't think that's good evidence because it produces more ulceration, larger bleed after 2-3 days. So the only way is to put a stent in these cases. There was one study from Mustafa Abraham's group which showed that if you do a hemospray, you can control the bleed, but again, very little data on that. Any endoscopic criteria to predict delayed post-polypectomy bleed based on the polypectomy basis? Here, I think we have a lot of evidence that polyp head more than 2 centimeters in size and the thick base is can cause bleeds, and that's why we do prophylactic clips or put a snare. Yeah, I think this can hemoclips be used in necrosectomy? Yes, it can be used in necrosectomy safely. Is doing INR not mandatory? No, the guidelines do not suggest INR before ERCP. I don't know whether we should in future use it, but generally we don't do routinely INR unless the patient has an associated chronic liver disease or other coagulative problem. The other question is incidence and predictors of air embolism during endoscopy. Now, I think this is very important. Again, Rakesh and Randir will agree we should take out this term air embolism. Yeah. We no longer use air in endoscopy. It is criminal. It is medical negligence. Change to carbon dioxide. Those of you who are using air, change to carbon dioxide. And carbon dioxide embolism is not a problem. Very often it's absorbed. It doesn't cause any problem. So no more air embolism. Regarding the size of cold snaring, to prevent delay, what should be the maximum size? Right now, most guidelines suggest 20 millimeters for a sessile polyp cold snaring, but I've seen in workshops and I've seen experts doing even 4 centimeters. So there's no actual size to limit, but in general, 2 centimeters or less is easy, but you can also do it for 4, especially in the right colon. I would suggest that even for larger lesions, you can do that.
In fact, there's a recent meta-analysis which has shown that comparing the cold snare polypectomy versus the cold snare EMR versus hot snare EMR in polyp size of up to 2 centimeters, the cold snare EMR had the same efficacy in complete removal and lesser complications as compared to hot snare EMR.
I think I agree, Randir, absolutely right. That's why I think more people. Yeah. Now, there's one question here on use of dabigatran. I think it's a totally new topic which we should discuss in detail in one of our master classes later how to use anticoagulants in endoscopy. So I won't go too much because it takes a whole.
Nagi, for that there is a very good consensus from ISG on, guidelines on how to use anticoagulants in endoscopy. So that is actually a very good.
I think we refer our questionnaire to that particular paper and how to manage glue embolization. Of course, the problem once you get it, so we can't manage. Is there a lot of banding in post-sphincterotomy bleed? No, kindly don't do bleeding post-sphincterotomy because you'll also close the pancreatic sphincter and you'll get post-ERCP pancreatitis. When will you use airway protection in massive GI bleed? This is also a good question that if you get a patient middle of the night with peristitial bleed or a massive GI bleed, if you have an anesthetic standby, kindly use airway protection. This is extremely useful. I would suggest that I use it much less than what we should. And then, of course, can gastroenterologists administer midazolam? We just discussed that legal point of view. I think soon Sandeep and Matthews are going to solve this problem for us. But very peculiarly, I feel midazolam is more difficult than propofol. It produces longer sedation. Unfortunately, we have been using that for long. I don't know why.
We have here in our recommendation in the hospital that gastroenterologists can use up to 2.5 milligrams midazolam in ASA 1, 2, and maximum 3 patients. So all patients undergoing endoscopies, their anesthesia risk should be assessed by the endoscopists, which we are not doing, which I think is extremely important that we should do, because as Nagi said, most of the more complications are because of anesthesia-related complications than endoscopy-related complications.
Yeah. No, peptide spray is similar to hemospray. No, there's a difference. Hemospray acts acutely. The peptide spray, in fact, acts long-term to prevent long-term bleeding. So the difference is there. And cirrhosis, what precautions during sphincterotomy also standard, and we have discussed this already. Can hemostatic spray be useful in variceal bleed? Only one study published in Gut, randomized study from Mustafa's group showing that it is useful. This is another question not related to this, so I won't go to SB tubes. How about doing ERCP without any sedation in a patient with hypertension? I mean, again, not a complication questions technique. If you have done more than 1,000 ERCPs, you can try this. Can air colonoscopy induce retroperitoneal air without any perforation? Yes, this can produce, but again, kindly don't do air colonoscopy. Do only carbon dioxide colonoscopy. And even if there's retroperitoneal air escaping through the small divertically, you can actually just wait, it gets absorbed. I think there are too many questions coming.
I just make one point about the question where there was asked during hypotension. We should understand that this medicine Dexmed or dexmedetomidine does not cause hypotension and can be used in patients who are hypotensive and you need to do an ERCP rather than propofol, because propofol produces hypotension.
I think we'll move on with the talk now.
Yeah, we'll move on to the second adverse event that can occur, which is perforation during, and again, most of the times perforation can be converted from an adverse event to an unplanned event because of our ability to close these perforations endoscopically. There are certain risk factors for endoscopic perforation. Most of them are like Zenker's diverticulum, dilatations, EMR. You recognize by subcutaneous emphysema, but I like to emphasize that the best way to recognize this is CT scan. Treatment can be conservative, very small, but majority require endoscopic clipping, very rarely going for surgery. Again, let me go into specificities here. This is a patient with Zenker's diverticulum. We are doing a Zenker diverticulectomy, and you can see as we cut here, we go very deep inside. Earlier practice, we are not putting clips. Now we routinely put clips in this. If we don't put clips, this is what can happen. This patient had cervical esophageal perforation. This can look very alarming. Immediately after the procedure, the patient couldn't be recognized. But one good thing about this is carbon dioxide is used, so it gets absorbed. It closes spontaneously, especially if we put clips. And these patients can be managed conservatively with 48 hours of Rayleigh tube feeding. Now, if you can have tears like this when you're doing endoscopy, sometimes the patient is retching in the esophagus. Linear tears can always be closed very easily with after experience with POEM, with clips like this, through the scope clips. Again, I don't want to discuss the merits of different types of clips that are available. That's another topic. But you can, depending on your experience, you can do. In fact, this is a lot of this adverse reaction management comes from the ESG update. The latest one is 2020. I'd recommend all the postgraduates to go through this position statement. It's freely available in the web. What they suggest is if you have an esophageal perforation less than 10 millimeters or vertical, you can use through the scope clips. If it is more than 10 millimeters, then over the scope clip. And for more than 20 millimeters stents, of course, you can use also for chronic perforations, you can use vacuum stents, but this is the current recommendation. And of course, all of you should become familiar with how the OTSC is used because this is useful. So management of visual perforation, identify the location, the size of the perforation, and what endoscopic intervention can be done. It also, I think, we should involve a multidisciplinary approach. Many times, after you close this perforation, you have to put an NG tube and, of course, antibiotics. Cervical esophagus perforation, nothing especially like Zenker's, just conservative care. And of course, large perforations, how to use through this, covered stems, and also stent fixation becomes very important because these people don't have a stricture. So just don't put a stent, use a stent fixation device that's now available, and this can actually hold the stent in place. We have used this vacuum therapy for mediastinal contaminations quite effectively. Now, coming to a few videos to show, this is we're doing an EMR in a patient with a esophageal, with a gastric. You can see that when you produce a perforation, there's a very good sign here that you find a lot of omental fat coming in. If you find this, you're very lucky. Quickly take out the clips and clip this. When you clip this completely, it closes very well, much better than regular clipping. And you can see we can take part of the momentum and clip it on and then clip the whole thing. And you can see after this over how it's effectively seen, and after 6 months, it completely closed. But if the size is more than 1 centimeter, up to 2 centimeters, these over the scope clips are very, very effective. Again, you have to learn how to use them. I won't go into the technicalities of how to use a grasper through this and use, but it's very easy. And I think these are several courses now by the SGA and ISG to how to use these clips. But what I'd like to emphasize is this new technique that, in fact, I learned from my colleagues, Zahir and Mohan, as they're doing a lot of third space or full thickness resections. How very large lesions, you don't have to bother 1 centimeter, 2 centimeters, and even 4 centimeter lesions can be used by this so-called king stick closure. You put a snare on this area, detachable snare, leave the snare in place, and then use clips to close the snare onto the lumen and then pull the snare. And then you find that you can close very, very large defect. Using this king's closure technique, I've seen them close such large openings that you don't have to worry at all about sending them to surgery now. And this is an example we have in this patient. We did a resection actually very high up in the G junction area, and you can see that after the resection, there's a large defect here. One part of the defect we could close, but others we could not close. So what we did was to use the snare, which is after taking out the specimen, you can see that there's a very large hole here. Normally, if we didn't have this technique, we would have suggested surgery for this patient. Of course, you control all the hemostasis first, and then once you control the hemostasis, you find this large gaping wound in the stomach opening into the peritoneal cavity. I remember that when we were doing the notes at early phase, people used to criticize us for making these openings. But now you can see this opening is very easily closed. Take the snare, detachable snare, put them across the wound completely, and put these clips, and then once the clips are all put, just pull on the snare, it tightens, and the whole thing is completely closed. So this is a technique, again, I'd recommend that all our junior colleagues going into third space endoscopy should learn, because you can close very large defects, up to 4 to 6 centimeters also you can close. I've seen them. Another technique, if we don't have this particular snare, is very simple. Put a clip with an ordinary suture there, bring it to the other side, and then you can put another clip to close this, to decrease the size, and then progressively this can be clipped. These are small solutions, so that earlier on our limitation, 2 to 3 centimeters, is gone. Majority of these can be now clipped using this. So this is just to show you the different techniques that we're now using to close these very large defects. Now, this is the ESG statement for gastric perforations. They suggest TTS clips, OTS clips, and you can see the addition of endoloop technique. In the esophagus, endoloop technique is difficult, but in the stomach, endoloop technique is very easy to use in these cases. So just get used to these techniques, and you can see in majority of the cases, you can control this. Sometimes even this cannot control, and this is a patient in whom there was a large wound. What we did was we put in stents and see what happens after putting in a stent, large opening like this. And this patient had to go for surgery, And of course, we can see that the surgeon found a large gap between the cyst cavity and the stomach. So it hadn't still come and become matter. That's the reason why early drainage of some of these wounds are going to be difficult. And again, two examples, large colonic perforation, duodenal perforation, colonic. Don't try to close this endoscopically, very difficult. Although, as I said, if the total transaction goes for surgery. So when should we call the surgeon when there's a perforation, endoscopic perforation? This is a difficult question. Earlier, you used to call them very frequently. Now, about 2 to 3% of our cases actually goes to surgeons because our endoscopists are not able to close. But what I would suggest is, in all the endoscopy units, you must have one endoscopist who's a specialist in closing these perforations. And I've found that the person who produces the perforation is not the right person to close it. Immediately call the other guy if you are working in a group. And he's calm, he has not produced a perforation, he doesn't have that moral obligation to the patient, and he can very easily close this perforation. So this is again the ESG publication. If you have a gastric perforation, very endoscopic or very early diagnosis, no specific, no sepsis, small defect, endoclips. Larger defect, OTSC. Or even if it's larger, you can use endoscopic clips. And majority, 99% can close this. But if you have late diagnosis, sepsis or a CT fluid air collection, then surgical management comes. Just to give you an idea of when to call in the surgeon. Now coming to the other area, the colonic, and this is where most injuries occur or more perforations occur. The type of perforations can vary. The so-called hockey stick injury. You see the hockey stick injury because the curve here, you can produce the perforation at this particular junction. And similarly, you have so-called barotrauma. There's obstruction, you keep on putting air, then you can get a perforation occurring very proximal. And retroflexion injury, again perforation. So many of these perforations, you don't realize you produce the perforation till you find distension of the stomach, or if you find when you palpate severe tenderness. So it's very important to look at the patient after colonoscopy basically for this type of problems. And the last type of perforation which you actually identify is thermal injury related perforation. If it's delayed after polypectomy, you don't. But when you're doing an EMR or ESD, very often you can see this and then you can close it automatically with clips and so on. So what I would recommend is that examine the wall when you do this. If you do a snare parallel, you can see the superficial muscle injury like this. When you examine the base, you can find a deep muscle injury and actual perforation when you can actually see the peritoneal fat. Yeah. So very easy to recognize. Almost all these perforations, 99% can be closed endoscopically, and this is no longer a complication. It's an unplanned event, which we don't have to worry. So if we have it during the procedure, endoscopic closure. If it's post-procedure, this is again, sometimes we find that the patient is absolutely all right, waiting in the recovery, and then complaints of pain. If it is small, you can even go in and again do, but majority of these delayed predicted problems have to go for surgery, especially because if it's a dirty colon, large perforation, mechanical injury, surgery is best. Small perforation, especially thermal injury, that is which is the commonest now, clean colon, endoscopic closure. This is just broadly to give guidelines to anger colleagues what to do. Closure devices are clips over the scope. For colon also now you can use this very easily. And again, the algorithm for colonic perforation from ESG is that patient is clinically stable and we send them off same day, evening home. But in majority of the cases, the symptomatic CT image is important. Kindly don't do plain X-ray. It's not going to be useful. The CT is the one you must do. And if there's a large excavation, then surgical repair is important in these patients. So I don't know whether we should stop here before, but we go to another area where there's the last area is ERCP-induced complications. Should we stop, Matthew?
Yeah, we can stop and take some more questions and then.
Okay. I think we are starting to see. Yeah, so no, I think the next also will be after the ERCP. And so we don't have, no, we'll get this after this next talk. So I think we'll continue with the ERCP. And
That's
then
right, Nagi. I think
we'll continue with the ERCP.
Yeah, I think
So
you
we
go
have some
ahead, yes.
questions on perforation. Maybe we take it up.
Are there any questions?
Yeah, there are.
There is
Actually,
one.
I don't know why so many people are watching and asking questions. So many questions are coming in.
There are two questions on, how to manage ERCP related perforation and what is the cutting and coagulation.
So I come to ERCP management as a talk on this. I think
There are questions. There are questions. There are.
yeah, the cutting and coagulation current in snare polypectomy, I think, again, this is something now with the intelligent electrocartridge becomes very easy to set up. You have actually a polypectomy or Q mode there, which gives sufficient cutting and coagulation, but it can individually vary depending on the type of procedure you're doing. With ESDs, for example, you have to know when to use swift coagulation or soft coagulation and so on. It's a whole different topic. And again, I suggest for Matthew and Sandeep, have one talk on how to use cartridge systems as a separate master talk.
Very important.
Yeah. Do esophageal clips can dislodge? Very rarely. Good clips nowadays, they don't discharge. Olympus has stopped making small size endoscopes. So now regarding the snare, which is to be made by Olympus, we have two other companies which are making detachable snares. I would recommend that you can go and get this company. I don't want to be a commercial agent advertising them, but the two companies which are making these detachable snares, you can buy these detachable snares and use them. Is there endoscopic management possible for peg tube stomach entry? Again, different topic. You can, of course, go endoscopically, dilate this opening, and then re-put the thing. My options for duodenal perforation, those with duodenal strictures. In duodenal perforation, this is a little difficult area, especially when you're doing side viewing endoscopy. I'll again come to that when I'm discussing ERCP, what can be done. Role of endoscopic suturing in stents. Of course, endoscopic suturing is another area. Not many people are trained in the Apollo suture technique, but if you are trained, it's very useful for using, especially on the greater curve of the stomach, on the greater curve in the duodenal area also. When should we remove SEMs placed for using? I would suggest that you keep the SEMs for at least 4 weeks. After you remove the SEMs, do a check.
You lost your voice.
That because we have some more. So shall I go to the talk now? Because questions many
Yes,
are coming.
yes.
Yeah.
Okay, I go to the talk. This second part is mostly an ERCP complication because ERCP, I think complications are the one which is very well defined based on this paper which came in 1996 by Marty Freeman and his group, who showed that pancreatitis is one of the most common complications, underestimated, quite devastating. 5% in average patient and high-risk patient, 20%. We now have many pharmacological agents, rectal indomethacin or rectal diclofenac, which is used to prevent this. Pancreatic stents in high-risk patients, IV hydration. So we have several ways to prevent post-ERCP pancreatitis, so that the average pancreatitis rate has come down now from 9% to 1 to 2% in most units. And this is the algorithm that ESG is recommended. I'll just go through this carefully with you. So if there's no contraindications for NSAIDs, I would suggest using rectal indomethacin or diclofenac. I would like to emphasize here that every patient in our unit going for ERCP, unless contraindicated renal failure or something, will get a rectal indomethacin, even for stent exchange. Some may argue, why do you want to give it for stent exchange? One, because rectal indomethacin is cheap, there are no side effects, and thirdly, because we won't forget that. We can't selectively put in some patients, then we'll forget. So all patients in our unit get rectal indomethacin with a, we actually put a stamp on the case sheet saying rectal indomethacin given. If after giving rectal indomethacin, in the standard cannulation, no further intervention. Difficult cannulation, we add pancreatic stent. Okay. Now, what about those? In addition, there is no contraindication to high volume fluid therapy. We always give ringer lactate. Again, there's a lot of debate whether what is the volume to be given and so on, but I'll simplify that a little later. If there's, you cannot give high volume hydration or if there's contraindication rectal indomethacin, I would consider sublingual glycerol trident. This is the only one which has shown to have some benefit in terms of decreasing post-ERCP pancreatitis. Of course, pancreatic stents in cases which are high risk. So what would I do? What we do is very simple in our unit. For all patients going ERCP, we give IV hydration, 1 pint of ringer lactate. Normal saline was ring lactate. Lot of studies showing ring lactate is more useful. Every patient gets a routine rectal endomethacin. And in some high-risk patients, we put pancreatic stents. We give another pint of ring lactate during the procedure, and post-procedure give 1 pint. So 3 pints of ring lactate are given during the ERCP procedure, and this gives a volume which we require is sufficient, not too much and not too less. This is a practical point. Now, the second complication, pancreatitis is discussed very often, so that's why I'm not discussing in detail. What is not often discussed is ERCP-related perforation. A very nice classification, type 1, which is a lateral perforation because of the scope. Type 2, periampullary because of sphincterotomy. Type 3 is injury because the guide wire going through the bile duct or pancreatic duct. And type 4, only free air. So let me show you examples of how each of these. This is an example of a type 1. This patient was being done in one of our workshops, one of the world's most famous endoscopists. He saw this papillary area and then came out saying he should not do anything. As he's coming out, see this injury, there's a perforation occurred, very pancreatic inflammation, sepsis, so on. This is a group of people who should be very carefully managed. What would we do? We are now routinely using OTSC clips in these people. Very easy to apply. Put OTSC clip, do a drainage, and what we do is, of course, put a nasogastric tube for nasojejunal tube for feeding, and within 2 weeks everything heals. But very, very high threshold, you should have be very careful. Low threshold for sending these patients to surgery. If you feel that you cannot do endoscopic therapies, go for surgery. Surgeons will put a drain and come off, but that is important. Otherwise, you'll get retroperitoneal sepsis. So somebody asked this question earlier on. I'm just trying to answer. Now, type 2, you can see here, sphincterotomy, we have done a cut. Some leak is occurring. In these cases, very easy. We put a completely covered stent. There are some which stay in place, some which don't. So use a stent which can completely cover with a fin. It stays in place. There's no problem at all. And usually we keep it for 4 weeks and take it out after 4 weeks. Type 3 is when a guide wire goes across. See this? We're trying to negotiate this leak, which is guide wire actually we thought has gone in, but it's actually gone into retroperitoneal space. And see how the air is quickly going in, how the carbon dioxide in this case. You don't have to worry because we use carbon dioxide. We just change the direction of the guide wire, put it through the opening, and then put a stent through this, and you find that either plastic or metal stents, any of those is enough. If it is very low perf, then you put a completely covered stent. Higher perfs, we tend to use uncovered. And this will automatically almost always close. We don't require to worry about these cases causing any major issues. The type 3, again, you can see a lot of air, but once you put a stent, it gets controlled. Type 4 is what is called the only retroperitoneal air or carbon dioxide, very common. So if we don't, after an ERCP, we find carbon dioxide lines around the kidney, don't worry, just leave it alone. You just follow these patients, you see that it completely disappears after certain, say, usually day 3, day 4. But the most important thing is we want to detect air after ERCP and suspect a perforation. The best way to do is with CT scan. Not only you see air, but if it's a large defect, you'll see fluid collection. That is important. The third complication, again, not much discussed earlier, is cholangitis. Cholangitis is very common if you do something like this. That is, you actually push in contrast without a guide wire. So to avoid this, we always now put in guide wire on both sides, or whichever side you want to go in. Only after the guide wire is in do we go in with the catheter, inject contrast, because we know we can drain this. So easiest way to prevent cholangitis is always have your catheter inside above the stricture before putting contrast. I think Randhir and his group have shown in a very nice article that using air cholangiograph can actually decrease cholangitis. So these are the two methods of how you can decrease cholangitis. But of course, washing rooms are very important. This is the area I think where we neglected in earlier period. Now most of the endoscopy rooms are having this good washing machine. Infections in upper GI and colon are not a major problem. Very, very low incidence. You should not worry about them. It's only in the ERCP, US, or invasive endoscopy that becoming a problem. And therefore, all of us have this duty to have well-controlled washing areas for our patients. I think it's an overkill to use disposable duodenoscopes right now, although we have them. My feeling is that maybe disposable cap should be used in all units for endoscopy ERCPs now, and this has shown in recent 2 RCTs that disposable caps can reduce the so-called CRA infections. Again, best way to prevent ERCP complication is not to do it, and do it only in those patients very strongly indicated. So I think we'll go to the ERCP questions now. I hope people have listened carefully because this is a very easy question to answer.
Poll questions, please.
Poll question.
Prashant. While they are project, okay.
Yeah. So the answer is already there.
Yeah, 100%.
Now we have a fantastic audience. They're listening. So it's, I think, true. I think there's no brainer in this, that we know that the only thing is very peculiar is that normally when you do rectal indomethacin and you add PD stent, you feel that maybe you increase the protection, but no. Network meta-analysis has done that using rectal indomethacin and pancreatic stents together does not increase the protection. For I don't know why, for some reason. In fact, there's a very large study now being done by Joseph Elminzer comparing PD stents for the rectal indomethacin and alone rectal indomethacin and or PD stent with rectal indomethacin. So should you do both or one? Right now, evidence suggests only rectal indomethacin is sufficient and IV hydration. These 2 things we must do in all the patients. High risk things like ampulectomy and so on, we use PD stents. I think Randhir and Rakesh should agree.
Yeah, that's right. Because many times people are not very familiar with putting in wire in the PD, and that can actually cause pancreatitis rather than prevent it.
Yeah.
And I will say PD stent, if you have put in a wire there and you're using a double wire technique, then preferably put in a PD stent before you bring out your PD wire.
Yeah, I think I agree.
Yes, yeah. If you are, I mean, ERCP related pancreatitis, the chances are increased if you even put in a guide wire. So if you go in with a guide wire, come back with a stent in PD.
Yeah, I think these 2 comments, Randhir and Rakesh made, are very important because people talk about double guide wire technique. I don't understand. Double guide wire technique you have to always put in a pancreatic stent if you come out. Otherwise, post-ERCP pancreatic. So that's the reason why now we advise put in a pancreatic stent and continue your ERCP rather than relying on double guide wire technique.
Yes. Nagi, one very practical problem that you have a patient on aspirin and clopidogrel comes with cholangitis. Any precautions, or if there's a chance that he can be postponed, will you do that, or you will go ahead with clopidogrel and aspirin?
Yeah, that's again a nice question because this is a common situation now. Many of our people are coming with a combination of cholangitis. So in these cases, if the combination, if they're using only aspirin, I'd go ahead with the sphincterotomy. But if they're using a combination, then I would put a stent temporarily, stabilize the position, because cholangitis itself is a risk factor for bleed. So I'll stabilize them and then see if I can stop, especially if the stent is cardiac stent has been put more than 6 months earlier. I stop clopidogrel at least temporarily and use only aspirin 75 milligrams, do the procedure and get them back after 5 days onto clopidogrel and aspirin.
Actually, this is a very important area where this is only area where I will avoid diclofenac suppository. Sure. Because if you are on dual antiplatelet or single antiplatelet agent and you add on a NSAID, the risk of bleeding increases manifold. So this is one area where I will go by hydration as the primary prevention and maybe PD stent rather than putting diclofenac.
Yeah, I think very nice point. Now regarding, we have few questions on perforation which you can take up. Perforation during esophageal dilatation, of course, in these cases, putting a completely covered stent is the best approach. Contaminated colonic perforation, 2 centimeters during colonoscopy, I would try and, I think most often the colons are prepared, so I try and, if it's 2 centimeters or less, almost always we can stop we can actually close it. But if it's larger, I'd like to go for surgical consultation. Is artificial CPR machines available to give pressure during endoscopy to avoid looping of scopes? No. We have scope guides that are available to tell you about the looping of the scopes. We use it in our unit, but not very popular. You can use that also. Buried bumper with a leak should be attempted endoscopy or should send to surgeon. Buried bumper depends on where this buried bumper is. If it is in the esophagus, very difficult to take out ourselves. But if it is in the stomach, for example, after a Vaughan stent, we can usually do APC and take out this. How to endoscopically manage TO? I think tracheophyseal fistulas are only managed with completely covered stent. Very small fistulas can be closed with OTSC, but studies have shown that chronic fistulas again come back. So we have to manage them using a combination of APC, stenting, and then putting it for at least 8 weeks, not 4 weeks. In patients with CKD and hypervolemia, how to prevent ERCP pancreatitis? This is again what Randhir has dealt with. There, the bleed chances are much higher. So be very careful about indomethacin. So CKD patients, indomethacin, we are very careful because of bleed. Volumes can be managed very carefully because you don't want to overhydrate them. I think there are several studies now. Do you recommend rectal NSAIDs for all or selective approach? For all, except the contraindication, all patients should have rectal indomethacin. Antiplatelet aspirin or clopidogrel, which one start? Again, Rakesh raised this point. If you have a patient, you can use. Now the recommendation is aspirin, especially 75 milligrams can be used safely. Clopidogrel, not as good as aspirin. Only after you complete the procedure, after 5 days, you can start both together. Why rectal indomethacin and not IV? I think it's a very good question. In fact, studies have been done comparing IV, subcutaneous, oral diclofenac. But for some reason, diclofenac rectal route is the best. Nobody knows why.
Yeah, I think, you see, after what are you preventing? Pancreatitis.
Right.
And where it is it in portal circulation. So if you give it directly a medicine into portal circulation, you will have a best potential for it to act. That's why rectal.
Yeah. So the issue sometimes a patient get violent. You're doing ERCP, but let's explain that. Role of transpapillary spraying of epinephrine to prevent. Again, a very good question. We have done a very large randomized, I think Rakesh also is involved, a very large randomized study on this and found that spraying epinephrine during ERCP does not prevent post-ERCP pancreatitis. The only thing I find in practice is that if you're doing a pre-cut, I'd recommend have diluted epinephrine with you. And as you're doing pre-cut, you keep spraying this epinephrine, decreases the capillary bleed and makes it easier to do the pre-cut. Then in obstructed system, air or contrast should be done after aspirating bile. Yeah, that is correct. In any obstructed system, once we get into the system, we always aspirate the bile before injecting contrast because you don't want to push the endotoxins into the blood. Ideal volume of ringer lactate, again, lot of controversies. Now we know that moderate or regular is enough. We don't have to overhydrate them with ringer lactate. So giving them approximately 1 ml per kg body weight per hour is sufficient. Difficult cannulation definition, 5-5 rule is good. Yeah. 5 minutes, 5 touches to the papilla is difficult cannulation. What is the consensus? I think NOVAX and EST, again, a very big topic. We should take it up separately. I think Matthew and Sandeep have suggested that also. If a patient is on cardiac stent within 6 months, what should be done? So that's again, we have discussed this several times during this period. If it is nowadays, in fact, our cardiologists are saying 3 months also is okay. You can stop for a few days if you want, but I would say heart is more important than gut. So 6 months, we can definitely put a stent.
There are some new stents, where he can actually stop early enough. You can.
Yeah. So in fact, there's now a new stent drug editing where they say you can stop after 1 month. But all these are not very definite studies. They are very early. So I would say I prefer that we be overcautious on this side.
Only one point here is that cardiologists prefer to continue clopidogrel in this situation in the first 3 to 6 months. And because the stent blockade rate is highest if you stop clopidogrel versus aspirin. So this is one situation where you may have to bite the bullet and give clopidogrel early rather than aspirin.
Sure. How to prevent post-ERCP complications, trainee involved. So I think this again, by supervision and seeing that trainee doesn't poke the papilla too much, I think we have to give a time limit. So what we do is that if you have an advanced trainee who's doing ERCP, if it goes beyond 10 minutes, I think it may look a little rude, but I think it should take over because it has been shown very clearly more than 10 minutes of trying to manipulate the papilla results in more post-ERCP pancreatitis. Cholangitis, unstable patient, I think we discussed this. How to approach a patient with warfarin. Again, this is going, I think you can see this topic coming up a lot. We should have a separate master session on that. Any role of ice water irrigation? No, there's no indication. Ice water has not been shown to prevent that.
Nagi, you have more slides to show?
No, I have only one more, but I can do it at the end of the talk.
Okay.
I think we'll go to the talk so that we have
Yeah.
15 minutes now, and then go to, because a lot of questions are coming in. I don't think
Now start the talk now.
there's
Here
one
I
nice
want
question
to
on coagulation in ERCP. There's a very recent study which has shown that if you use pure cutting current and not a combined cutting coagulation current in ERCP, you can decrease the incidence of post ERCP pancreatitis. So we tend to use a mixed current, coagulation and cutting, but maybe we should think about whether we should use only coagulation current. Anyway, I come to this special area as POEM. I think people should start now looking at complication, because that's a common procedure that's done. And fortunately, you look at it, the major adverse reactions are not so much with POEM. It's much less than what we initially thought. What one should be aware is most of this, like carbon dioxide insufflation, bleeding, mucosal injuries, all this can be controlled very easily. One of the problems with endoscopies, unlike surgeons, is that we tend to overemphasize our complications. We don't put them in proper place. And this has unfortunately resulted, for example, in the spiral endoscope being withdrawn, because minor complications like erosions were reported as complications. They are actually unplanned events. And then people took a serious view of that and thought many complications. So I think we should have a very balanced view. One thing should be very clear, that however good you are at endoscopy, this complication is bound to occur, and these statistics always catch up, because endoscopy is not an exact science. There's a lot of operator variability, patient variability, and so on. So I think you find that some days when you come in and do your ERCP, nothing happens. Some days you have pancreatitis in 2 or 3 patients. So this is sometimes can't be explained, but can we minimize it? I think this is a very important, again, the checklist manifesto book that all residents should read by Atul Gawande. He actually read it for surgeons, showing 9 steps of how to decrease iatrogenic complications. But an endoscopy also, I think we can do. We have now, at least in the more invasive techniques like POEM, ERCPs, and we have a checklist nurse who looks at various things before we start the procedure. Example, in POEM, patient ID number, and of course, we all this now not in all the hospitals. The equipment is checked, especially the cautery equipment. We don't check the cautery equipment, and suddenly you try to coagulate in a bleeding patient, you find it a problem. So equipment, whether water jet is working or not. And again, very important, especially when you're doing third space, see that the carbon dioxide. I've seen instances even in major units by mistake, they don't switch on the carbon dioxide and you have air problem. And of course, with the anesthetist equipment. With the ERCP, always make sure rectal endomedicine is given what type of hydration and so on. So these are checklists. I think all of us should get used to using this checklist, post them on the side of the endoscope trolley, put a nurse or somebody who is in charge of this, who will checklist for all the patients. You can actually prevent many of these complications. The second area where again we're not trained well is how to break the news of complication. We are told that if you produce a complication, go honestly and tell the attendant that you produce complication. Sorry. I don't think sorry, that won't work, because I find it very difficult if you produce a complication to say directly to the patient, sorry, I produced a bleed and this patient died. So I think we should be taught the art of breaking a complication news. And of course, this is a very old article from Peter Cotton. We showed that the main reason why people go for lawsuits, it's not because of the complication itself, but because they have not been properly informed. Informed consent is not taken. So I think that we all know informed consent becomes a part of our, I think, therapeutic endoscopy. We should behave just like surgeons. Surgeons will take at least 15 minutes, the anesthetist, surgeon, everybody explains. But sometimes we do that. I think we should change our fashion. We should start doing a more informed consent. Training, of course, is another area very important, how we train our residents so that you can get better. You can see a very young Jahid training on symbiosis. He doesn't require training now, but still, training becomes very important. And I think, again, this is a society, we should have mandate on this. Animal lab, how much training should be done? What is the number of hours of training in animal lab before we go on to doing procedures in humans? In surgery, laparoscopic surgery, they got very good mandates now and guidelines which they are following. I think we should also, from the society side, do this. If any message that comes out from this talk, it should be that we should have society guidelines of amount of training before we do this very invasive procedure. The third important thing is endoscopy audit. And what we have done in our unit is that we have monthly an endoscopy audit. All the endoscopy complications produced in that particular month. For example, last month, minor and major were 25. We sit down and discuss what are these 25 complications, how did they occur, where could have been prevented. Again, this is something we don't do, but endoscopic audit has become very important in all major international units all over the world, where at least in a month we can sit down, discuss what are the complications, what are the potential steps that could have prevented this complication. And in our own unit, we found that this has made a dramatic difference in terms of when this occurs. For example, we used to do glue injection for fundal varices. After a patient died after doing glue injection, we decided that no, this is not the way we should do. Every patient who has to have fundal varicose glue injection, however small it may look, will now get admitted, worked up fully, complications explained, try and do coil with glue. If it's not possible, only do glue. So this has changed our practice, and after that, we haven't had a problem. So I think this is very important. And again, we have to follow what surgeons and anesthetists do. We are behind them. The other thing we should do, again, this is to society, Matthew and Sandeep, we should do what is called the multicentric quality network. If you don't do this, this is done in many units in the United States. What they do is very simple. So many of the top units come together. You put in the net, what is your cannulation rate, for example. It's all very impersonal. That is, nobody knows which unit. Say the average cannulation, biliary cannulation rate in India is 80%. If you're doing 100 or 90%, you're good. But if you're at 60%, something is wrong, you have to improve. So there should be multicentric quality networking, which can be done in a fashion where all the units are linked together. You can put the data into the web. Nobody knows where it's coming from, whose data, but you know the average data. So we can do this quality networking for many types of endoscopy. For example, ERCP, US, third space endoscopy. And this way, I think, will improve the quality of endoscopy, decrease our adverse complications. At least we'll know what is the adverse events in our country. We try to get the data, it becomes very difficult. Nobody wants to publish. But if it is obscure, if nobody knows the unit name, then they're willing. That's okay. So this is now the other last part is how you actually report endoscopic complications. Earlier on, it used to be mild, moderate, severe based upon the number of days of hospitalization. 1991, Peter Cotter's classification. This has changed now, and now I think I'd strongly recommend this AGRI classification, which has come in GI endoscopy recently. This is a classification based upon what surgeons do, the CD classification, what anesthetists have, their classification. So the Dutch group and the European group got together to do this AGRI classification. It's adverse events gastrointestinal endoscopy, where a complication is graded into grade 1, grade 2, grade 3 based upon the type of complication. Very well defined criteria. Again, I'd recommend the society that if we endorse this, all of us can use this standard classification, and we can then report and saying we have, say, 50 units in India doing major endoscopic procedures. Based on AGRI classification, this is the adverse events we had. I think this is also very important in terms of showing that endoscopic society in our country is progressive. We can compare with the best of the world. So this is my final slide, just to show that endoscopy, like everything else, is a teamwork. And I think if we work in teams, we can definitely decrease our adverse reactions. Thank you. Maybe we can come to the last one.
Can you show the last poll question? Prashant? We have total 10 minutes more for question and answer.
Yeah. So the answers are already there?
The questions are actually shown to them. They may start polling again.
No, I think we are also very educated. I think the last part, the audience are awake. Everybody is giving right answers.
So we could go back to the questions. There were a couple of questions left.
Yeah, maybe you can go to the chat box and look at them, because this looks like everybody is now sure of how to decrease the adverse reactions.
One important question was, I always wonder why there is no significant risk of infection in the third space tunneling.
Yeah, I think third space tunneling is very safe procedure. In fact, that's probably much easier than ESDs also. One of the reasons is, I think, Randhir, I feel that most of the people who are taking up this are trained a little in animal models. They're supervised much better, because people are very worried about third space. So you see, wherever units have started this, there's been somebody, senior person, going there and helping them initially. The fourth reason, of course, is inherently it's a safe procedure because it's contained within a space. So any bleed can be very easily controlled. We're using carbon dioxide now, so perforations are not a problem. So I think
another thing, Nagi, which I think is because there's no increase in pressure on the, inside the space, because the problem of infective complications happen maximum when there's a
infection. Yes. So this is funny. In fact, when we initially started doing POEM, we did a study with our microbiology department where we took all the things and cultured, and we find that when you do the culture, you find a lot of candida growing, a lot of bacteria growing, but actual infections don't occur. And we just published a recent paper on a single dose antibiotic or no antibiotic and found the no need of antibiotics in these cases. One of the reasons we believe is that because you're using a lot of cautery here, the heat burns out the microorganisms. There's very less microorganisms there. Why should SGA statement on, there's some question here for SGA. They want a statement on reuse of accessories.
I'll answer that. Actually, there is a consensus guidelines is being going on. So soon you will get that.
Okay.
It's already SGA is already on the work of that, and it's almost the work is getting partly over, but we are getting more information from that.
Yeah, I think we had a meeting also with.
Nagi knows that, and Rendir also was there.
Yeah. So there's one question on how to control the carbon dioxide. Unfortunately, the carbon dioxide meters don't have a control, but you can control the tubing. There's high flow, medium flow, low flow tubing available. If you're doing third space, you just switch to low flow tubing. The tubing comes from the manufacturers. You can ask them and put a low flow tubing. That way you can control. There are some newer equipment coming out where you can actually control the flow of carbon dioxide. But presently, the ones that are available, best is to control it with the tubing.
How much time prior to ERCP rectal endomethacin to be given?
Yeah, that's again a very good, important question. We used to give it later after ERCP. A very good Chinese study in Lancet 2016 showed that if we give it half an hour before the procedure, it's most effective. So all of us now tend to, of course, sometimes precisely half an hour may be difficult because you're busy and the ERCP may go a different time. But in general, half an hour to 1 hour before the procedure is best. Not too early and not later.
Now, most of the times it is given on the table, no?
Yeah.
Yes,
So,
yes.
on the table, if the patient is, sedated, maybe sometimes socially easy. But what I find is that there's different study. Half an hour before is more protective.
Professor Kochar, there is actually a comment on why in third space there is no infection. Rindhir has asked that question. No, actually there is a comment from the audience, which I think that is also relevant. It's because of the high lymphovascular clearance that happens in the cavity. This is a space where a lot of lymphatic circulation takes place and clear all this. That's also
actually, it's all guessing now there.
It's all guessing. There is no theory. No.
I think this question of double channel endoscopes, just double channel endoscopes are there, but we don't require to use the anchors in double channel endoscope. If you have a single channel also, you can use an anchor to close the perforation. So double channel endoscope are useful mainly for suturing, where of course now you have single channel also for suturing, but that's the main use. But specifically for perforations, they're not extra use. So are Savary-Glad reusable or not? As Savary-Glad dilators are reusable. The plan for post. This is again for SGA. I think it's an important question which Matthew and Sandeep should take over. Is there a post SGA accreditation, post DM accreditation? Unfortunately, our country doesn't have this. We are actually trying to work with DNB, National Board, to see if we can introduce a post DNB or post DM, 2 years or 1 year advanced endoscopy course. At present, we don't have it, but I think we should think of this also.
It's a major area we need to work on that. I think the whole of Indian faculty needs to work on that.
The question is, in ERCP reporting, do we need to write the number of inadvertent PD candidates? Of course, ideally, but very difficult to do it all the time. But if you're doing any research project, for example, we have done several projects now on post-ERCP pancreatitis. One of the questionnaire always is how many number of times you have gone inadvertently into PD. But remember that even if you go once, the chance of post-ERCP pancreatitis increases. More than 3 times, definite. So that is very easy to count. You don't require to be a mathematical genius to count 3. So I think 3 is okay, but you don't have to put it in the form.
Yeah, putting it into the record will be, a medical legal
problem?
issue
I think
later on.
you're
So,
right.
I think it should be written. That is what I practice always. It's written that how many times you guide wire went into the pancreatic duct and all. I think that's important.
the number of times it has gone, but in the guide wire went into the PD. That should be enough, and a PD stent placed.
Yeah.
That's enough.
I think now we have come to the end of the time also. Again, I'd like to
Yes,
thank
yes.
I think,
Sandeep for giving me this opportunity for discussion and excellent moderation we had today.
We are thankful
So
to
I
you,
think
sir.
what comes out of this, apart from the technical part of it, how to manage, a few standout things have come out. One is that proper training, particularly for advanced procedures like third space and of course ERCP as well. And an audit should be done as far as possible, even amongst the single solo practices. This audit that what has been happening in the last 1 month or so, and to prevent it, one must be prepared, have enough accessories of the right kind. Equipment should be good, and all the basic precautions like carbon dioxide and availability of the basic accessories. Some of the things which have been pointed out may not be available in a solo practice, but then the limitation should be understood by the endoscopist. And we should not hesitate to seek help. As rightly pointed out, that the mental issue which crops up, that you have created a perforation, how do you close? You are shaky, you are slightly worried about it, and call for a second person to help. That's something very important, and that will take care of a major hang up in the mind of the endoscopist. And follow the agree classification. We must do that, and I think it is time that both ISG as well as SGI have our own recommendations for different things like the anticoagulants, particularly, and all other things, reuse of accessories. We tried to formulate that some time back. That should be more widely disseminated.
Yeah, I think we had a wonderful session, but apart from what we all discussed, many times the problem comes when you are using something expensive to control the complication or to treat the complication. That's why the communication with the patient's attendants is very important. You applied a OTSC clip, you have increased the cost by 45,000 rupees. Similarly with the fully covered SEMS and multiple clips. So this has to be told that the alternative for treating this complication are these, and then patients attendants will agree. Otherwise, in today's scenario, the opacity in your complication and its plan of management will create more problems for the endoscopist than being very clear about it, that yes, it has happened, it is part of the procedure, and this was because that will be in part of your consent form. And so if once you express that and tell them the cost upfront during consenting, nobody will get it done. But after, if the complications happened, you have to share with them the options which are available.
Okay, I think now we have come to the last part of our session.
To comment from my side, thank you, Dr. Nagi, for your great inputs. And we have one chapter in progress in gastroenterology this year about settings of electrocautery by Dr. Jayanta from PGI. And I totally agree that there should be multi-centric quality networking, very, very important. And we should have a master class on endoscopy in a high-risk group, particularly in reference to anticoagulants as well.
Yeah.
So may I take this opportunity to thank Dr. Nagi Reddy for his wonderful lecture, and very practical and divided into different subheadings. It was very useful. There are a lot of questions, and I'm sure we could not answer everything, but I'm sure we will just see whether we can actually answer them on follow-up period. And Dr. Rendhir and Professor Rakesh Kochar. Thanks a lot for your time.
Thank you,
and
sir.
Comments. Excellent. And this is a
Thank
very
you.
wonderful session. So we have to conclude now. And once again, I thank all the people involved,
Thank you.
technical team, and especially
Thank you,
Nisha,
sir.
our ISG support and secretary. She did a wonderful job. So the next meeting is on esophageal dysmotility disorders and how to manage that. And that is by Professor Udeshi Ghoshal, and that is on August 13th. And I request all the participants to take part in this and also disseminate about this course, because it is such a wonderful course. What is happening in, because you have heard the lecture of Dr. Nagi Reddy and last time Dr. Professor Sarin, and it is all well attended. And today it's almost more than 500 people attended. And I am getting a lot of feedbacks from people who are attending that such a wonderful talk. And I think we need to disseminate this. And there are even participants from outside India, from Malaysia, and many from Middle East also. So I thank all of you and thank the participants.
Thank you.
Also. Thank you so much.
Sir.
Bye-bye.
Thank you,
Thank
sir.
you.
Thank
Yeah.
you.
Thank you. Thank you.